Oi,
So,
Flávio. Bem?
vamos lá. Good afternoon, everybody. Welcome to Telemedicine, International Telemedicine Grand Rounds. This year 14 of this meeting. Today you have the privilege to have a case presented by Brazil, by SBITE, and by Hospital Municipal Adão Pereira Nunes, one of the trauma centers that have in Rio de Janeiro, Brazil. The case will be presented by Jéssica Pinheiro dos Reis. She's a general surgery resident, Hospital Municipal Adão Pereira Nunes, Duque de Caxias, Rio de Janeiro, Brazil. And the case is going to be supervised by Dr. Flávia Ramos. Thank you, everybody, for joining us. And Dr. Carlos Menegoso from SBITE Brazil going to be the one moderating the section today. Thank you. Hey,
Thank you,
Carlos.
Doctor. Hi, how are you? Hi, everyone. So thank you for joining the session today. We're going to have Jessica Reis to present the case, and I'm going to call some colleagues to be the panelists. I think that Dr. Untrak, Dr. Kassim are there, and I see also Dr. Lenin, and also the other colleagues here, Calderon, and I will call you guys to make your comments. So, Dr. Jessica, feel free to start whenever you want.
Hello. I think my internet is not. Can I start to present?
Yeah, sure.
Yeah.
Feel free.
Okay. So hi everyone. My name is Jessica. I'm a general surgery resident here in Rio on my second year, and today I'm going to present a case that we had on our service 2 months ago. And we start with this little joke that is a bullet in the chest with a warm welcome from the lung that I don't want to spoil our case now. So we start with the case that is a male, 17 years old, not known to have any medical illness, brought to the ER with
Jessica.
a gunshot wound on his right.
Jessica, it didn't
Sim,
change
yeah.
the slide.
Oh. Sorry?
Colocar em modo
It
de
didn't
apresentação, Jéssica.
Yeah.
You can see that?
Não estava no modo de apresentação.
Entendi. Wait a minute.
Aí não muda o slide. Compartilha quando estiver no modo de apresentação.
Sorry. And now? It's passing?
Não está no modo de apresentação.
Oh, but it's here. Using the modo apresentação. Wait a minute.
Quer fechar e abrir de novo e aí você compartilha no...
Então, o daqui está no modo apresentação.
Talvez você tenha que clicar quando você põe share screen na tela, que é o modo apresentação. Põe no modo apresentação, daí quando você pôr share screen, abre várias opções, clica no modo apresentação, tá clicando nas suas notas, nas suas notas. Põe o share do screen todo, não só o PowerPoint.
Não tô indo. Share. Here. Aqui vai aparecer o cara junto. Ah, tá. Share. Esse agora foi.
Não
It's
foi.
not working.
Tá mostrando aquela barra
Can
do
we
lado,
leave?
tem todos os slides e depois a...
Que barra do lado? Share. E o screen
Aquela
share.
que mostra os slides do lado, entendeu?
Isso.
Ah, tá. Agora põe isso aqui para
Não está no modo
apresentar.
apresentação.
Isso, tá sharing, mas não tá apresentando. Então, e agora? Foi?
Não, porque ele fica estático. Você tem que sair e voltar. Tem que stop
Quando-
sharing, botar
Quando
no
você
modo de
selecionou
apresentação
o
e share.
que vai share, você tem que pôr no modo apresentação primeiro, daí quando você pôr o share, escolher a janelinha que está a apresentação, modo de apresentação.
Volta lá, põe aqui, põe para apresentar e depois põe sharing.
Isso.
Agora vai lá no share. Mas agora eu não consigo ir para a página. Põe alt tab. Aí sai.
Então põe share screen só, não só o share PowerPoint.
Isso, faz isso. Mas é o que eu põe lá no sharing de novo. Põe só o screen aqui. Agora põe lá no apresentação e põe para apresentar. And now, it's working?
Perfeito.
Tá indo?
É isso aí.
Ok. Graças a Deus. Então vamos lá. So, the case. It's a male 17. We start?
Yes, go ahead.
Yeah, go ahead.
Okay. It's a male 17 years old, not known to have any medical illness, brought to the ER with a gunshot wound on his right arm. He was conscious and alert, hemodynamically stable, complaining of ventilatory dependence, pain on his right chest. On clinical examination, there was minimal bleeding. The entrance wound was in lateral of the right arm, and there was no exit wound elsewhere. The rest of the exam was unremarkable. So I brought here the image to show you where was the gunshot wound. So we received the patient and we need to do the ABC of trauma. He had no signs of airway obstruction. He was talking with me all the time. He had no cervical injury. He had adequate breathing. In his auscultation, there was no sound on the right chest. He, as I said, he complaining about the right ventilatory pain. His respiratory rate was 18 incursions per minute, and his saturation of the oxygen was 98% on air room. He had the pulse are present, and his blood pressure was 120 of the systolic and 840 on diastolic. He had no signs of brain injury, and his Glasgow was 15. And on the E, we saw just the gunshot wound on his right arm. So in this point, what do you do on this case?
Great, thank you, Jet. Yeah, I'll start the rounding with the panelists. Dr. Untrak, do you want to start?
Yes, well, based on the history, the reported physical examination, and the title of the presentation, obviously the bullet seemed to have gone into the right chest, where it was warmly welcomed by the right lung. So in this case, I would check for pulses in the right arm, which I assume were present. If not, you would have mentioned that they were absent. And I'd get a chest X-ray. Before that, I'd look with the ultrasound to confirm either pneumothorax or hemothorax or pneumohemothorax. But I would get a chest X-ray and look to see if the bullet is there, and I would expect to see the radio-opaque foreign body. So that would be my next step, and I prepare for a chest tube on that side.
Excellent, thank you. Dr. Kassim, are you there to comment? So let's wait for Dr. Kassim.
Okay, I'm here. Can you hear me?
Yeah, we can hear you.
Okay, good. Well, suppose you didn't have the title of the talk today, you would be thinking quite different, wouldn't you? So you will say, oh, it's an ordinary bullet wound to the right arm, and let's look at it locally and let's not worry about distant, such as heart, lung, cervical vascular system or something like that. You wouldn't be doing that. But the title obviously gives us a clue that this is not going to be a local problem, is going to be a migrating bullet. Did it travel along the brachial artery, or did it travel along the brachial vein and lodged into the pulmonary system? And did it stay in the pulmonary system? Did it just go there and visit and then migrated back into the heart and gone through the circulation? I have seen a case where something like this happened and the bullet ended up in the foot, which is not not very common, and it was actually missed for several days till they started thinking about it. Where is the bullet? They couldn't find it anywhere. But be as it may, and there are some signs telling us that something is happening to the right lung or right thoracic cavity, and you should at least get a chest X-ray. While you're getting a chest X-ray, you should also get a KUB to make sure the bullet has not migrated infradiaphragmatically. And that's what I would do. And then get ready for whatever invasive procedures that you are thinking of doing. Thanks.
Great. Thank you, Dr. Kassim. Dr. Lenin, would you do anything different? Would you like to comment on this case?
No, I mean, you don't have any breath sounds on the right. I mean, sometimes that can be, a technical issue, but yeah, you got to get an X-ray. See if the bullet got into his chest or her chest.
Great, thank you. So, Dr. Jessica, what did you guys do in this case?
So we start with hydration, and we gave him meds to his pain, and we request a X-ray of his right arm. As we can see any fracture here and his pulse over present. So we don't request an evaluation from the orthopedics or vascular surgeons. And if you try hard, you can see where was the entry wound here in the right chest. In right arm. And then we request a chest CT to see what happened in the butt.
Acho que ela caiu, Flávia.
Peraí.
Tranquilo. So I think that she lost connection. She's going to connect again. I just wanted to use this time to ask you a question, to ask the panelists a question regarding the evaluation of this case. So when do you feel it's necessary to do more tests when you regarding it, mainly the mainly arterial injuries in the arm, if you have penetrating injuries in the arm, but if you have normal pulses? Dr. Untracht, would you comment on that?
When to do more tests? Well, if the blood pressures are equivalent and normal in both arms, the doctor mentioned a blood pressure. It didn't mention which arm the blood pressures were recorded in, but I would be sure that they were equal bilaterally. And I would do more tests if there was concern about contusion of the vessel, or hematoma compressing a vessel. And if everything else were stable, and in this case, the patient has an injury in the involvement of the chest, so that's where the focus should be. But if the injury were limited to the arm, you could proceed with arterial Doppler studies of the axillary and brachial arteries, and then down into the wrist if need be, just to confirm whether there's any injury. But in this case, I'd be concerned more about what's going on in the chest. And in any case, you have time to do studies because the patient has normal blood pressure and normal hemodynamics.
Perfect. Thank you. Dr. Jessica, you can continue.
Yeah, so we did this X-ray in the right arm, and we didn't see any fracture here. So I bring here the CT of the chest. This is the parenchymal window. And as you can see here, we start here with hemothorax associated with the lung contusion here. We saw the bullet really close to the large vessels here. And a pneumothorax. A little pneumothorax, but it's present. And to confirm that he had pneumothorax, I bring the mediastinal window to see. The bullet here. So, what to do next? Observe, put the chest tube, or remove the bullet. What do you want to do?
Okay, let's start with Dr. Kassim.
Well, the first thing you want to do is to make sure that the bullet is actually extravascular, intrapulmonary, or extrapulmonary. You have to determine where exactly the bullet is. If the bullet is lodged in the lung parenchyma and it is totally escaped the vessels, which is unlikely because you have a significant hemothorax there, it must have got, the bullet must have hit something, unless it just hit the intercostal vessel and went straight into the lung. And so it's the intercostal that has caused the bleeding and given the patient the hemothorax. You want to make sure that the bullet is in a position that you can either observe, or you want to do further tests to see that it is actually escaped the total vascular system on the right side of the lung, i.e. pulmonary vein and pulmonary artery. It is kind of surprising that there is no entry wound in the chest itself. I would expect to see some type of an entry wound in the right chest for this bullet to be in the right thoracic cavity. So what my concern is, I need to know the total location, exact location of the bullet before I determine some type of a remediable situation for this patient. Chest tube is important. You need to drain the hemothorax, and also you should decompress the pneumothorax, even though the pneumothorax is pretty small. But the chest tube should be pointed to the base rather than the apex. I think the pneumothorax was dissolved by itself unless there's a continuous air leak. The hemothorax should be drained. You don't want to leave a hemothorax gone because it becomes clot formation, and then it causes all kinds of other problems. Thank you.
Great, thank you, Dr. Kassim. Dr. Lenin, would you agree with the chest tube, or would you treat this conservatively? And if you perform the chest tube, would you do anything to try to decrease the risk of having a clotted hemothorax?
Yeah, I mean, I probably would have got a chest X-ray initially if we seen that hemothorax. Put a chest tube in right there. I wouldn't send anyone to the CAT scanner without breast sounds, even though he's sounding well. And then usually irrigate the chest with the chest tube. And then you got to decide what to do with the bullet. It's hard to see on that CAT scan. There's going to be scatter from the bullet around the great vessels. Doesn't look like there was contrast given during the scan. It's not always helpful when it's that close to the pulmonary vessels, but you'll probably get a scan with contrast to see, definitely to see, and include the arm to see if you can get the trajectory of this bullet. And then, you know, if it's just an intraparenchymal bullet and the chest tube output is manageable, the lung, you know, just leave the chest tube alone. Just leave the chest tube. If you know, the other issue is that if you think it's intravascular and it's proximal, you know, there's some options, you know. I mean, you can try a transesophageal echo to try to localize that in the proximal pulmonary vessels, see if it's in the vessels. But I think you really have to identify if that's intravascular or not. But I would definitely put a chest tube and irrigate the chest and treat a hemothorax like a hemothorax.
Great, thank you. Dr. Untrak, what about you? How would you try to figure out where the bullet is?
Yeah, well, about the question, what to do next, I would do all three. So I'd put a chest tube in and then see where the bullet is and remove it. And I think if you can find this, the assailant, you should probably admit him to med school because he seems to be able to hit the subclavian vein better than a third-year surgical resident. I mean, what a good shot that was. And what Dr. Kasim said initially, it seems to be one of those cases of a bullet embolus. It looks like, I'm guessing, but it looks like, based on the CT scan, it's in the right inferior pulmonary artery. And so you just need to figure out where it is so you can do a CT pulmonary arteriogram, you know, a CTA with looking at the vessel, see where it is. And if it is in the pulmonary artery, then I think interventional radiology should be able to remove it with a basket. But if it is there, it needs to come out because it's an embolus blocking the right inferior pulmonary artery. But that's what I would do here: put the chest tube, confirm where the bullet is, and if it is intravascular, try to remove it interventionally without thoracotomy.
And Dr. Untrak, just to spice things up, would you use a pigtail or a conventional chest tube?
No, I would use a conventional chest tube. Usually like a 28 French is adequate for this. It doesn't have to be huge, but big enough to be sure that all of the blood is evacuated. And as Dr. Lenine said, you can irrigate through it very easily. But I would do, you know, not too big, but 28 French should be okay.
Excellent, thank you. Dr. Jessica, you want to continue?
So what we did, we put the chest tube and we saw 200 milliliters of blood was immediately drained and we saw air leak through the tube. So the next step, we needed to study the proximity with the vessels, with the pulmonary vessels. He was stable all the time. He didn't show any signs of shock, but we request the CT angiography of the chest. And here we go. So, wait a minute. We didn't see any lesion here near by the bullets. the vessels are okay. So the bullet was near, it's close enough, but don't lesion any vessels, pulmonary vessels. So 6 days later, we saw an expanded lung, no air leaking anymore, and a low drainage under the 100 milliliters, a serious debit, and he had no symptoms anymore. And what now? We removed the chest tube, or we can do anything else for him.
Dr. Jessica, just to clarify, so this is 6 days later, right?
Exactly.
Okay, and
Yeah.
how was the patient from day 1 to day 6? Did you do any other?
His pain, it was okay?
He was stable all the time.
Sorry? Yes, all the time.
Okay. Okay. Dr. Cassim, do you wanna jump in?
Yes, I would have done, because of the scattering of the bullet, because it's the metal and the CT, and you get a lot of scatter there. And I don't know how confident you're going to be in saying, well, it's outside the pulmonary vessels. I probably would have put a catheter into the heart and squirted and contrast into the right pulmonary system so that I can get a much better view of the right pulmonary vessels. To ascertain myself that I'm not overlooking. Because as Dr. Lenine says, initially when you saw the CT, there's quite a bit of scatter there. And metal under CT always does a lot of scattering. You may not get the kind of detail that you're looking for in a case like this. Just my thought. So in order for me to go after this bullet, it is extremely vital for me to know exact location. I need to be 100% convinced in my own mind that is where it is so that I can go after it with impunity. Thank you.
That's great. Thank you. Dr. Lenin, any thoughts on this part?
Well, you hate to do something on someone who's doing well, obviously. I mean, it's like you never want to hurt someone who's doing well. But a couple things. One, I think on the CAT scan, you always try to make sure they inject through the other side because the IV contrast, the venous contrast on it is kind of limiting what you can see there. Like you want to know how the bullet got in there, right? You want to know if there's something, you want to see the pulmonary, the axillary vein, the subclavian vein. You want to see, you can't really see it on this. And then, the bullet, I'm still not sure where the bullet is or how it got there. It may be inside the vessel and maybe just what you're seeing there on the CAT scan is an infarct of the lung, which is, I guess you can live with that, but a long term, I guess, what's the risk of leaving that in? So, I mean, could he develop a pseudoaneurysm or AV fistula or something like that could develop? I mean, but again, like it's difficult to do something to someone who's otherwise asymptomatic, so I think I just would have feel more comfortable if you really know that this bullet went through the lung and is sitting there rather than went through the vasculature and is sitting there.
Yeah, great comments. Thank you. Dr. Untrax, anything to add?
Yeah. So on the CAT scan, did I hear correctly? You said you could not see the bullet in the chest? Is that correct?
I mean, you can see the bullet
No.
in the chest. I'm not sure you know exactly where it is still
No,
for how it got there.
From the doctor presenting the case, that the bullet is, and second CAT scan on the arteriogram, the bullet is in the image or not?
Yeah, it is.
It is. So where was it? Not in the pulmonary artery, or where was it on the? What did the radiologist say?
It was very close to the pulmonary artery.
Oh, but outside the pulmonary, so it's in the lung.
Outside. Yeah.
Okay.
Yes.
Yeah. Then right. Then and the patient's doing well. Then I kind of agree with Dr. Lenine. If the patient is doing well, there's no evidence of any other injury. So it apparently, so I would retract my offer for the medical school admission. He just poked the lung, dropped the lung, didn't cannulate the vessel. But if it's went through the lung, through the axilla into the chest and sitting in the lung, I suppose you could leave it there, and if there was any question, then maybe with a thoracoscopy, you could see if it's there. And it's right near the hilum, so it's outside the hilum. It didn't injure any of the mainstem bronchus or any of the vessels, and it's right there. So I suppose it'd be easy enough to remove. If you did thoracoscopy, you could remove it, know it's out, and it won't cause trouble. But I kind of agree with Dr. Lenine. There's no what's the risk of leaving it in place versus the benefit of taking it out, and the risk of the intervention to remove it. So that's the calculus to consider.
That was our problem. The risk of leaving it there.
Yeah.
And
So
make an erosion to the wall.
Yeah, if you think it's lead or it might move, but it's not gonna, if it didn't perforate the vessel, then I can't imagine that it would just be sequestered, and but if you're worried about lead poisoning, then I suppose you could follow the patient lead levels and then see how he does. But and then if you're very skilled at thoracoscopy and can remove it, then fine. I would give that a try without causing any harm.
The problem is it's really hard for us to follow a patient here, especially that type of patient,
Yeah. And that goes into the equation.
Definitely. Yeah, thanks. Very interesting comments. Dr. Jessica, do you wanna proceed?
Yes. So we start to think, remove or not remove the bullet, and we have 3 thoracic surgeons here on our service, and 1 was against to remove, and 2 of them are in favor to remove. The argument to the one that he was against was the bullet is retaining a soft tissue. It will be enveloped in a fiber scar, so probably it remains stationary over the time on the lung. And the other ones, they told that the migration can occur and lead to the complication that involving the surrounding tissues in the lung. It can occur recurrent infections, and the most important, that the bullet was in the pulmonary hilum, so it's close enough to the large vessels, and we decided to remove the bullets. So the next discussion is about which technique we would use, the VET or the open thoracotomy. So I bring here a description about the VET that is significantly reduce the risk of postoperative complications like infections of the wound in the thoracic cavity, reduce atelectasis and pneumonia, reduce chest tube drainage volume, the duration of the tube, and the duration of the hospitalization and operation times, of course. And the amount of bleeding and the transfusion volume inside the operation is really low compared to the open thoracotomy. Of course, the patient have a small wound and less pain. And the contraindications to the VETs is a obliterated pleural space, inability to tolerate single lung ventilation, hemodynamic instability, circulatory shock, and life-threatening thoracic injury. And of course, our patient didn't have any of these contraindications. And the procedure of VETs require experienced surgeons we have in our service. So we opted to use the VETs. And now I bring some of the videos of our surgery. So this first one, we show that we put the camera on the previous incision that was with the chest tube. And here, wait a minute, I'm going to pause. We can see the hole that the entry bullet, the entry wound, where the bullet entered to the lung. And here is a penetrate injury. That's where the bullets enter on the lung. We can see it's the hilum, the pulmonary, the vessels in here. The second one, we show where we did a incision. We made an incision on the 50 intercostal space to use our video clamps. And we saw a little bit of serous debit. And this third one, we can show you where we're trying to find the bullets. What happened in the surgery that the fluoroscope wasn't available. We waited for 30 minutes and it wasn't available for us, so we need to convert the surgery. So we opened the thorax, the chest, we enlarged the previous incision that we made in the 50 space. Here we can, I don't know if you can see, we can see the injury, and the bullet was here. I don't know if you can see, but it's in between the upper and the lower lobes of the right chest, of the right lung, and was really near of the hilum. So I mark here that the bullet was here around. And I bring the photo of our bullet. Is a little bit, but it can happen. So after we remove the bullets, we test if there was any fistula, because we remove and we need to suture. So we start to inflate the lung, and as you can see, it has a fistula. So we sutured on the local, and then we tested again when we didn't see any fistula anymore. And in the end, we put a chest tube to drain all the tablets. So after the surgery, he went to the ICU, to the stabilization, and he had around 400 and 300 debits per day, sanguineous, and he was stable all the time. And he stayed in the UCI only 2 or 3 days, I can't remember now. And then we go to the room to stay with his dad. And this X-ray, this chest X-ray, was 3 days after the surgery. We can see that the lung was it wasn't expanded at all that it could be, but he had still having an air leak, and the debit was around 200 milliliters. And 7 days after the surgery, he was doing respiratory physiotherapy, and he was walking, he was stable, there was no pain anymore, but the lung is still incarcerated. And we recommend to continue the physiotherapy, and he was doing great. We couldn't see any more air leak these days, 7 days after. So he had only around 100, 200 milliliters of serious debit, and no air leaking anymore. And we start to discuss what to do. The lung wasn't expanded at all, but he had no more air leaking, no signs of fistula, and the lung was incarcerated. So we discussed with our thoracic surgeons, and we opted to remove the chest tube, and he went home and with the condition to continue the respiratory physiotherapy. So 20 days after the surgery, he was on his home doing the physiotherapy, and returned to us to evaluate what happened with the lungs. He was stable, no, his breathing was okay. He had no symptoms anymore, only in the where we opened with a little bit of pain, but we can see here that the lung was a little bit more expanded compared to the 10 days after, but not expanded too much. But we said to him that advised him to continue his respiratory physiotherapy and return for medical appointment 1 month later to see what happened. But unfortunately, he didn't came back. So we hope that he is doing well. And that's it. That was the case that I bring to you. I don't know if you want to comment if we did right, we did wrong. I don't know. Anyone have any doubts?
Yeah, Dr. Jessica, thank you very much. I'll ask the panelists as well for their comments, but I just wanted to ask you about what do you think happened? So it seems that the entry wound in the chest was missed in a sense, right?
Yes. I think the bullet, maybe it did it was deviated on his bone. I don't know.
I think she lost connection again.
You know, the only entrance wound was in the arm.
Yeah, only the arm, right? So
Yeah,
maybe
yeah,
it
with
traveled through the subcutaneous tissue.
Exactly, probably, because there was nothing there. That was he had only one hole.
Yeah, and you, because you saw the entrance, the entry wound from the inside out of the thorax, right? In the VATS procedure.
Exactly. Yeah,
okay.
we did.
Okay, it
But
makes
there
sense.
was nothing in the skin.
Yeah. Perfect. Dr. Untracht, any comments?
Yeah, so I guess you saw the wound in the rib cage at the apex, didn't you? When you did the thoracotomy or the VATS? You did, right? Okay.
Yeah.
So it went through the axilla, right? That you would expect that, but so the chest tube post-operatively, was it functioning? Was the water level ascending and descending with respiration, or that would be my concern, that maybe the chest tube wasn't functioning, and I would consider maybe putting a second chest tube to be sure there's adequate suction, because the lung should expand.
I'm sorry.
It was functioning.
It
There
was
was some air leak. Yeah, there was some air leak at the beginning, but then it stopped.
and the lung wouldn't come up, but it's not entrapped. It doesn't look like like you had the patient. Well, if it wouldn't expand and the patient had symptoms, then he would need another VATS and a decortication, to get the lung to expand. That either be, and then the other option would be a mucus plugging, the other possibility. But he was coughing well. Gave him the chest physiotherapy. So it doesn't look like a case where there's occlusion of it have to be occlusion of multiple bronchi or the main stem bronchus, I suppose if he's doing well, he had no symptoms, eventually it would have expanded. So I think it's probably reasonable what you did. And it's unfortunate that he didn't come back. So either he's doing great or he got shot again. God forbid. I don't know. That he got, depending on the neighborhood. But there you go. Interesting case.
Great. Thank you, Dr. Untracht. Dr. Kasim, any final comments?
Well, when you did the thoracoscopy, you saw the wound in the chest. And now, if there is a wound in the chest, there must be an external evidence of chest wound. It cannot magically appear that. So I'm kind of a little puzzled how this could have happened. And I'm trying to think all scenario to explain for that. I'm at a loss. Well, I'll leave it at that. So I think after removing the bullet, you need to test that area with installation of several liters of saline and inflation of the lung to make sure that there is no bubbling occurring at all. If there is bubbling, I think you need to go after it in the initial procedure, because that's the first chance and the only chance you're going to have to plug the hole, whatever is bubbling, and you can't just walk away. I think that's what I was taught. So I think I would have gone back and looked at it carefully and plug the hole somehow, even if it requires some type of mobilization of tissue, even intercostals, and to put the whatever is available for you to plug the hole to make sure that there's no air leak, because it could be a side branch of one of the bronchi or something, and they don't heal very well. And if they don't heal, you will have this residual pneumothorax, and the lung does not expand, and you are stuck with it. We used to, where I trained in England. When we have something like this, sometime we will create a right pneumoperitoneum or pneumoperitoneum to allow the right diaphragm to go up as much as possible to obliterate that airflow space in the thoracic cavity and take care of that. And that's one of the techniques we used to do. I don't know whether they do that sort of thing nowadays or not. I'm not sure. So interesting case, a lot of mystery, and unfortunate that you didn't have fluoroscopy available, because you would have been successfully removed it through the VAT procedure, and then you had to resort to a mini thoracotomy, cut all the muscles and everything, which is going to be painful for this fellow. Anyhow, he's non-compliant. He didn't even show up for the post-op follow-up. So I think he probably is going to have further problem down the road somewhere. Great case, nicely managed, Nice pictures, good presentation. I enjoyed it very much. Thank you.
Great, thank you, Dr. Kassim. Yeah, and if I understood correctly from Dr. Jessica, they did find the bubbling during the first surgery, and they put some sutures there, right?
Stitches. Yeah, you're right.
Yeah,
We did find it.
yeah, maybe it. I mean, nevertheless, there was a post-operative leak, right? Okay.
Exactly. And
So
we tested it again after the sutures, and there was no air leak, no
yeah,
bubbling, so we closed it.
Oh, I
Great.
see. So you did try to repair it and you got a successful repair, but the repair broke down afterwards. Is that right?
Yeah, probably.
Right. Very good. Very good. Thank you.
Great, thanks, Dr. Leni. Any final comments?
I mean, it's a very, very interesting case. All of us rarely deal with these type of problems, like kind of difficult decisions to make, whether you operate on this guy or not. But I think one thing you can do, which I don't know if you have, but when you don't have fluoroscopy, we have there's like laparoscopic ultrasound probes now. We use them for the bile duct. They can be used for this. But they're pretty helpful. If you can do an ultrasound, you can use the probe. I mean, it's pretty easy. And I think, what do you do about the lung not really fully expanding? I think after this type of thing, I think it's a kind of expected, it'll get better with time. I think you did the right thing. Once the tube was not draining, you took it out, just let him recover at that point. So.
Great, thank you very much for the comments. Dr. Jessica, thank you very much for presenting, and Dr. Flavia as well for being here with us and supervising the case. Do you have any final comments before we close the meeting?
No, I just want to thank you, everybody. It was a great opportunity, and I hope that I made myself clear. I was a little bit nervous about English, but I think in the end it was okay.
No problem, it was perfect. Really nice.
Perfect.
You're great.
Dr. Antonio?
Yeah, thank you, Dr. Jessica, Dr. Flavia Ramos, Dr. Menegoso for representing Sbite Brazil on this meeting today. I have a lot of ties with Hospital Adão Pereira Nunes. A lot of work there before the 2014 FIFA World Cup and 2016 Olympic Games. Great friends, a lot of special people working there and keeping the legacy of the games until now, right? With the work that you did in Brazil to get ready for the next level of trauma care. Congratulations again. Looking forward to have you all next week here. Next week we're gonna have a meeting from Miami, and then in 2 weeks probably gonna have like a case of pre-hospital care, a very interesting case of pre-hospital care. Okay, thank you all, and see you soon. Take care.
Thank you.
Bye. Thank you.
Obrigado. Excelente, Flávia. Muito obrigado, viu? Jéssica, boa.
Obrigada, gente. Obrigada, Flávia.